Hello everyone, this is Lisa Johnson from Everbridge, the Senior Program Manager for Healthcare. Welcome to today's webinar, CMS Interpretive Guidelines for Emergency Preparedness with Bob McKee from Boston University. Bob has an extensive amount of background in emergency planning, everything from firefighters to disaster preparedness, crisis planning. He has been the person executing tasks, he has been the person directing tasks, he has been overlooking command centers, kind of soup to nuts. He has seen almost every aspect of emergency planning. And he has been in the thick of the CMS Emergency Preparedness Guidelines. He has spent months and hours and hours reviewing the documentation as it's been coming out and talking with his colleagues in the field. He has a great depth of knowledge about the CMS Emergency Preparedness Guidelines, and we are very happy to have you here today, Bob. Thank you.
Well, thank you, Lisa. So I'm sure all of the participants, each of you are getting inundated with CMS. We've talked about it. It's certainly been a process that's been ongoing now for a few years. So how does it affect? What is the meaning? What we wanted to do today was, just for the sake of all the participants, is review a little bit about the regulation and then talk mainly about the interpretive guidelines that came out. And talk about, all right, we are 3 months to go, what do I do? So let's talk about some actionable items. What I would suggest right now is be thinking about your questions, because Lisa and I are certainly willing to help you through those specific questions, through resources, what other people are doing. As mentioned, we're both very connected into the realm of what others are doing. So we certainly want to make this helpful, and we want you to take away something from this webinar. So the CMS regulations, again, they've been discussed for the last couple of years, leading up to the pre-announcement and then the announcement a year ago, November 15th. Hard to believe, but it's going to be here before we know it. We need to be prepared. We need to do our very best, even though there may still be some confusion from the standpoint of understanding and appreciating what the guidelines say and how they're going to be measured. But again, that's what we want to do today, is to help you with, okay, now what? So the final rule, again, was published in interim a year ago. Almost, and the idea behind that federal CFR, the Code of Federal Regulations, was to discuss the safeguarding of human resources, maintaining business continuity, and protecting physical resources through an emergency management plan. There are 4 key elements of the CMS rule. Again, if you've been a part of those, you know these in and throughout. But again, from a point of reference, it's important to cover them. Risk assessment and emergency planning. The CMS guidelines approach this in an all hazards manner. So we're not looking at one type of disaster or crisis, we're looking at all. The importance of alarm notification systems. So not only internal but external. So how do we literally and figuratively sound the alarm, and how do we notify? Policies and procedures, which are stronger and have more teeth than just operating guidelines. They ensure the successful execution of the emergency plan. So we have to have a plan, but then we have to exercise, we have to train and implement that plan. We have to be able to staff, we have to be able to work with our staff, our patients, our clients, our contractors, our PRN staff through contracting agencies. We have to be able to track them during and after an event. As part of this plan, we must have a robust communications plan. Communications, I'm sure you'll all agree, are not only an important part of our everyday, but they're a very important part during a crisis. Uncertainty reigns true, and so communication is what is that sustainment, that opportunity to provide calm to an otherwise chaotic situation. The emphasis on patient care and contact with physicians and staff is key, as well as within the communication plan, how do we transfer information? Not just verbal information, but medical records, for instance. How do we remain compliant with HIPAA and other organizational requirements? And then the fourth key element is training and testing. So the guidelines talk very, very significantly about not only the initial and the ongoing training, but how in fact this is done. One of the key words that comes out of the guideline is knowledge. Knowledge. Then lastly, the drills or the exercises that occur must be done based upon the Homeland Security Exercise Evaluation Program, or HCEP, guidelines. Breaking these elements out a little bit, the risk assessment and emergency planning, we must assess and develop an integrated all hazards plan that addresses the capabilities specific to our organization or our facility. Each of the facilities are different, and I'm sure all of you on the call have looked at the guidelines, have looked at the interpretive guidance, and you see the 17 different provider types and facilities that are identified. There are unique requirements for each. However, generally, these are going to include patient accountability, alarm notification systems, and your available capacities. These will be reviewed and updated on an annual basis, regardless of the survey which is conducted by the CMS auditors. Policies and procedures must be developed and implemented, if not already present, that support the risk assessment. What are my risks? What are my vulnerable areas? The emergency plan and the communications plan. While in some cases you will have communications as an internal aspect of the emergency plan, for the purposes of the CMS rule, they are two standalone documents. Implementing these policies and procedures will make sure that we have a system that can track all on-duty staff, our sheltered patients and clients, both during and after an event. The communication plan, as we mentioned, we must develop and maintain an emergency communications plan that complies with state and federal law, incorporating the contact information for the healthcare providers, and we have to make sure that there's an appropriate and compliant method for sharing information between transferring facilities with regards to HIPAA and other compliance organizations. And then the fourth core element broken out is the training and testing. We must develop and maintain a training and testing program for all new and existing employees. All employees must demonstrate knowledge of emergency procedures, evacuation routes, and patient instructions. Annually, a full-scale facility or community-based exercise must occur, and an additional exercise of the facility's choice must also be included annually. When we talk about the interpretive guidance, I'll give you some more specific examples of each of those. So one might ask the question, what if I just choose not to do this? What if I choose to wait and see? Part of the initial guidance that was presented, as well as follow-up correspondence, CMS made it very clear that no exceptions are going to be granted, and that the outcome of this will have the same non-compliance effect as with any of the COPs or the CFCs. So essentially, what does that mean? That's going to hit me in the financial pocket. So the interpretive guidelines were presented. It's about 72 pages of additional information specific to each of the sections, primarily generated from the amount of questions or correspondence that occurred. And within those, the secret is that the answers to the test are within. So if we look at what's going to be reviewed, we're going to be able to see what in fact is going to impact us the most and how can we apply that to our planning. Of the many takeaways of the interpretive guidance, there were two big takeaways. One, the continual message of plan for the worst case scenario. It's difficult for one to have a crystal ball and to say that the next disaster implementing plans within my facility will be X. However, what keeps you up at night? What are the items that you know as professionals are your vulnerabilities? Is it communication? Is it critical access? Is it transportation? You're well aware of what those are as an organization. So planning for those and then creating an opportunity for improvement is the best advice that all of the documents, the CFR rule itself as well as the interpretive guidance, can offer. And then secondly, community planning. I'll talk in a couple of minutes. Community is better defined in the interpretive guidance. And essentially, in the simplest terms, the community is both the internal and external stakeholders that our organization and our jurisdictions rely upon. What we need to be considerate of is to involve the widespread, the most impactful organizations and individuals as we plan for these crisis events. So looking specifically at the interpretive guidance, and again, I'm sure most of you have been through it more than once, these are the things that really jump out. These are the things that are being discussed in a number of the forums and the blogs. These are the things that other organizations of various provider types, as well as the emergency management professionals, are discussing. So in the interpretive guidance, if you don't have them in the resource material, we can certainly provide you the link. But the clarification that's provided is more specific to the facility and the provider type. So while there was some ambiguity that was lent to the original rule of, now wait a second, it says this applies to all hospitals. However, if a hospital has a freestanding urgent care or a freestanding acute care facility, what does that mean? So a lot of those definitions and those specific clarifications were offered. Additionally, the interpretive guidance outlines the survey procedures. Back to what I had said a few minutes ago, here's the answers to the test question. This is what we look at. What are the individuals going to be reviewing? So if, for instance, the question of testing knowledge as part of the training element, what does that mean? We're going to look at training records. We're going to look at attendance logs. We're going to look at instructor qualifications. Those are the types of things that help outline what those survey procedures will look like. Certainly, the interpretive guidance is encouraging planning. Plan, plan, plan. It's going to expand upon some of the language, such as the privileging and the credentialing. During a crisis situation, you're going to have a staff recall, and you may even have agreements with other private nursing companies, private facilities. All of those come into play, as we'll talk in just a couple of more minutes, as it pertains to the training, the testing, the privileges, the communications, and the credentialing. So ensuring that anyone that is performing service, whether clinical or non-clinical, is a part of that same scheme is important in the interpretive guidance. Engaging now with your local emergency responders and public safety officials is key. If you haven't already developed a strong relationship, this is one of the things that can help you the most. That as you look at planning an exercise, as you look at actually executing an exercise, the emergency responders have just as much to gain by helping you as you in asking them for help. So please use that as a loud call for assistance. Understanding that any variations to your existing training programs are a little bit better defined in the interpretive guidance. And then lastly on this slide, communications throughout the plan. Communications is a key element that parallels each of the areas and should be taken very, very seriously. In the interpretive guidance, one of the things that's discussed in detail is the whole community approach. So as mentioned, the community is, again, the internal and external stakeholders. It's literally the community of suppliers, vendors, your local jurisdiction. It's the essence of those people that both rely upon your services and your facility, as well as those you serve. Succession planning or delegation of authority is key throughout the interpretive guidance. So what does succession planning mean? From an HR perspective, it's a strategic imperative to look at planning for that continuity of operations. In this particular case, it takes a little bit further and says you should train the person above you and below you on your skills and necessary actions. So essentially, we're all cross-trained, not just from the clinical standpoint, but from the managerial standpoint. And then if there are freestanding facilities in which the administrator may be off-site for a period of time, what is the delegation of authority? If the administrator is the only person that can sign some particular orders, that's not a good place to be in the time of a crisis. So we need to have, in the event of a crisis, the delegation of authority can be to X. And those need to be planned well in advance. Individualized emergency preparedness plans was something that was discussed in the interpretive guidance, specifically to home healthcare agencies. So the fact that as a home healthcare agency, we need to ensure that individuals have an emergency preparedness plan in their home, meaning what is the evacuation procedure? What are their emergency call procedures? Those are things that are going to be part of the survey, which is conducted by the CMS auditors. The use of volunteers and contractors. The use of volunteers and contractors, we have credentialing. So are they able to be in the space that they are? And do they meet the training requirement? We have to ensure that they have the same level of training as do the employees. So it's going to take time to investigate what those PRN staffing agencies and per diem organizations have, for instance, as well as the contractors and the volunteers. What training do they have from their organizations, or if they're directly affiliated, what training are you offering them, such as fire extinguisher training, recognition of evacuation routes, patient assistance, etc. Provision planning is also discussed. In some cases, we have to ensure, based on the facility, that provisions are provided for staff and patients. Those are better defined in the interpretive guidance so that indeed we can look at what does that mean, because certainly on the first blush of the rule, that was quite a broad statement that with the interpretive guidance, it's helped define that. There's more discussion about the full-scale exercises and what does that mean? What do we follow? How do we do those? How often? And then again, circling back because it is important, the community is defined. So now what? Gosh, a lot of information. I hear what you've said, Bob. I appreciate these things. You know, it's been on my mind and been part of my daily job now for several months. Now what? So some of the highlights: communications. Again, we cannot stress this enough. The people to consider in this realm are essentially everyone, but in particular, the staff on duty and off duty, our contractors and our service providers, volunteers, the physicians, and the other facilities. So do we have communications networks in place? Do we have call lists? Are we using some sort of a platform? And have we exercised that type of platform? During an exercise, what if we determine that we can't get a hold of someone? What is our second and our third method? How do we prioritize those? These are key, particularly as we discuss essential personnel. I spoke earlier of succession planning. Again, as you'll see the arrows, we need to train up and we need to train down so that we have resilience. We cannot assume that my particular role is something that someone can step in and replicate without knowing what are those key things, particularly in the time of a disaster, that need to be carried out. Who gets access? How do they get access? What if our card reader system goes down, our biometric systems? Who has all the physical keys to a facility? Where are they located? How quickly can I get those? And then again, as discussed earlier, and specifically on page 13 of the interpretive guidance, that if in fact the absence of an administrator or the person who's legally responsible for the facility is not available, then who can be that delegated authority? Having that discussion early, understanding and putting in place policies and procedures will define that in a much better, more organized fashion. Again, discussing the provisioning, whether it's food, whether it's medications, whether it's support materials. The provisioning is critical, and understanding how that is more better defined in the interpretive guidance is certainly worth your time, particularly if your provider type calls for that level of a requirement. Communicating with the local community. The rule says that facilities are required to have primary and alternate means of contacting staff, your federal, state, regional, local emergency management facilities, acknowledging the fact that in most cases this has been met. However, in some cases we're hearing that, well, how do I get a hold of them? Where is the best resource? The best resource is going to be your local or regional resource. And if you need then to have state and federal authority contact information, it would be through and with your local and regional authority. So essentially what they can provide is additional information. They can provide additional staffing. The picture here is a command briefing at an event. So during an exercise, they can help fulfill roles. They can help provide you with suggestions in the fact that this is an everyday occurrence for your local community professionals. This is a great graphic because it's so depictive of the fact that reaching out to other facilities in our local agencies is truly as simple as that aerial view of a map. So again, whether a hospital or a freestanding facility, whether an organization, a public safety organization, we think about all of the churches and religious communities. We think about all of the schools and the support areas. We think about city government, county government. This is important because this is the genesis of an appropriate plan. That while an individual facility may have an impact, it's the whole community which is going to deal with and mitigate that and return the events or the conditions to a new normal. Communications during an evacuation are very, very important. If you've heard one thing about communications throughout the webinar, that's what you've heard, because communications are not just for disseminating information, they're also receiving information and transferring information. Any of you that have been involved with either transferring out or receiving patients in more than just one or two ambulances at a time will appreciate that there are staffing requirements, there are other resources that need to occur, there are compliance measures such as HIPAA that come into play, there are supply issues, particularly if it's a traumatic event, if we have injuries due to a tornado or some other event. We also have occupancy information. So how do the hospitals work on bed occupancy and the availability of emergency department access as well as capacity? And then what do we do to log that event? Documentation of the event is critical, particularly as we look at state and federal disasters. If there are state and federal declarations that are made, funding becomes available, and your event logs will be critical. Always establish a primary and a secondary way to reach your staff, contract, and volunteers. These are things that may seem minute on a daily basis, but are going to be critical, particularly if we have a need for accountability. If we've had an event in a particular facility and we need to account for everyone, how can we account for everyone if we didn't know they were there to begin with? If there was some sort of an exposure and we need to contact people after the fact, how in fact will we document that? How will we reach out to them? So again, proactivity in this case is best. So what concerns you most?
That was our last slide, right? Yeah.
Yes.
Okay. Just double checking. So we have gotten quite a few questions in during your session, so that is great to see. We have quite a few to go through. I do want to remind everyone that if you are looking for a copy of the slides, several people are. We will be emailing them out by Friday, so you'll have that. It will also include a link to our YouTube channel. If you actually want to search for Everbridge on YouTube, we'll pop right up and you can see all of our webinars. There's a healthcare playlist that goes back for a couple of years with a lot of information, so it'll be up there as well. So if you have any other questions, please go ahead and do that. Wow, we do have a lot of questions. So I'm going to just dive right into it. So what is the difference between an emergency management program versus an emergency management plan, and what will CMS be looking for?
In that particular case, I have read that, and I've read comments on that. Is the plan is defined as the specific action, the specific plan that is digital or it's on the shelf. An emergency management program is all-encompassing to look at all aspects that are necessary. So within that, we're going to have a plan that says we're going to do A, B, C, 1, 2, 3, and our emergency management program is going to include our exercises, our training, our after-action reports, etc.
Thank you very much. And then that segues nicely into the next question, which is, can you define a full-scale exercise in different to a functional exercise in a healthcare setting? Great question.
Again, terminology, depending on where it's coming from. A functional exercise is in essence the same as a full-scale exercise. The full-scale aspect of that is essentially using the entire community of resources. So what we would do is a functional exercise would look at a sector, a department, it would look at a function. So can we provide 400 extra meals during the height of lunchtime, for instance? That would be a functional exercise. A full-scale exercise, again, from the premise, is the same thing. However, we're building upon it to have other functional areas. So we're going to have 2 or 3 or 4 areas that are being tested, as well as bringing in our local emergency responders. So the fire department shows up, EMS shows up to augment the needs in the emergency department. So it is more multifaceted than a single functional exercise.
And then I apologize that I don't know what this acronym stands for. I thought I had them all memorized. Somebody has an ASC on site, on a hospital site, and wants to know if they need to be considered as part of the plans, and then sort of a little bit broader than that, we've gotten a few questions about physician practices on hospital and off hospital, who actually does need to do them, and what do they need to do? Does it vary by type?
Okay, so yes, to answer the question, it does vary by type, and the very best resource is going to be the provider supplier definitions that CMS provides. And in there, it actually very carefully defines who you are by their terminology and what you are. So again, the difference between an all-inclusive care for elderlies, which is a PACE, versus a long-term care facility, which is an LTC. So not knowing the specifics, it's difficult to answer, but I would point you to the CMS guide for provider types, and in that, it will very clearly define for you what your requirements are.
Yes, and if I could add on to that, if anybody is looking for additional resources, we will be sending them out in the email. But if you go to everbridge.com and just type in the search bar CMS Emergency Preparedness, we have an entire library page which has 6 or 7 webinars, 5 or 6 white papers, and it does include that list as well, all of which you can download for free. I love this question. How do other hospitals communicate with staff who are off duty if the phone lines are down?
Great question. We need to be concerned with the local infrastructure, and the phones are certainly the way to communicate. We've gotten used to that. In my many years of practice within emergency management, we would rely on one particular method. That method goes down, and now what do we do? A number of us no longer have home phones. We rely on our mobile phones. One of the things to keep in mind, and this is through years of experience, particularly in hurricanes and other weather-related events, although a phone system goes down, there is typically, and this is not a rule, but there is typically still text capability. So just because a system goes down and I cannot make a phone call due to the availability, there may be the opportunity to send and receive texts. So this is something to discuss with your providers and your professionals, but I think a caveat is important in that particular case. Additionally, a call list should include not only Bob Smith and the phone number, but also Bob Smith and his address. For those of you that live in weather-related areas, it may be that you have to pick up key essential staff, and that has been used in both winter events, but as well in weather events, that it may be something that you've got to go get them, bring them into the facility. So think about those opportunities of how do I get a hold of my critical staff, my essential personnel, and it may be a physical contact as much as an electronic.
Thank you. That's very thorough. Let's see. And I wanted to add, some hospitals are setting up either a private blog page or a private Facebook group for staff, so that perhaps if you have a landline or you have the ability to somehow get online if you can't receive a phone call, that they're posting notices there for staff to stay on top of things. How are hospitals best ensuring compliance with maintaining a list of staff, patients, visitors, contractors, etc., on site on a day-to-day basis within the hospital?
There's 2 primary ways. One, I'm aware of a number of organizations that are using electronic measures of check-in. They're essentially standalone, so whether through a swipe system or an RFID system, The RFID systems are widespread. That essentially it's a proximity device that you're there. It records you in the system. When you leave, you're gone. Sign-in logs are still being used in some smaller facilities. And then lastly, a tiered approach. So as we used to do fire drills in school, the teachers would account for all of their classes, and then the teachers would report up through the chain to the vice principal and the principal. Another method that's being used is department heads or sectional areas that account for the people that are in their area, whether they be contractors or visitors, and then reporting an accountability that's then collated and coordinated at the command center level.
Great, and could I add to that a little bit, Bob?
Yes.
What we see with our clients when they're going through implementations is oftentimes human resources has the lists. And so they have the ability to, at the very least, update contacts, and HR is very on top of employees that are coming and going. They don't want to have an old employee on their books, so those lists tend to be very updated. And then that's sort of one piece of it, and then another piece that our clients frequently use is scheduling software, so that, you know, when somebody clocks in on their computer, they're logged in as in, or they have a clinical schedule and they can coordinate with that. So that is something that some of the hospitals can use. So this is going to be our last question. It's a good one. We haven't had this one before. So what is the role of a home health agency in regards to community participation?
Great question. I'm actually going to use my interpretive guidance because I was specifically looking at the home healthcare agencies. There's some really unique requirements, and if you haven't looked at the home healthcare section of the interpretive guidance, I would recommend it because, again, what we're looking at is the responsibility to ensure preparedness at the individual level, and as such, taking care of your clients, your patients first, and then in the community aspect, your staff, clinical and non-clinical, may be a resource to others within the community. So it may be something that you provide, but then it also may be something that you receive. So particularly connecting with the local emergency responders and ensuring that, say for instance, flooding, as an example, is mentioned in the interpretive guidelines. Flooding would be something that you would need to evacuate. Again, your responsibility as the HHA is to ensure the plan is there. However, the actions would be up to that family and through the typical structure of a local community support.
Thank you so much. That was a fantastic answer. And with that, we're going to conclude today's webinar. If anybody has any questions about Everbridge, about our services, about what we can do, or if you have a follow-up question that you think of in a day or two that you'd like to ask us, you can email me, lisa.johnson@everbridge.com. And we will be sending out a copy of the slides and a link to the recorded webinar by Friday of this week, so you'll be able to review it with yourself and any colleagues. Bob, thank you so much for joining us today. I'd like to thank the audience as well for taking the time, and we will talk to everyone soon.